Let's begin with the etiology of filariasis. Filariasis is a parasitic disease that is caused by thread-like nematodes, or roundworms, belonging to the superfamily Filariaria. There are 8 species of filarial nematodes that cause disease in humans. These species can be classified into 3 groups based on the niche within the body that they occupy. Lymphatic filariasis is caused by Wuchereria bancrofti, Brugia malayi, and Brugia timori. Subcutaneous filariasis is caused by Loa loa, Onchocerca volvulus, and Mancinella streptocerca. Serous cavity filariasis is caused by Mancinella perstans and Mancinella ozardi. Given the vast scope of this topic, we will focus mainly on the roundworms that place the heaviest burden on human populations worldwide, beginning with lymphatic filariasis. Lymphatic filariasis is a widely endemic disease that, if left untreated, can result in chronic lymphedema known as elephantiasis. It is estimated that 1.4 billion people are living at risk for this disease. Roughly 120 million people are currently infected across 73 countries, primarily in Asia and Africa, as shown in this map, of which 40 million have experienced disfigurement and disability due to elephantiasis. Bancroftian filariasis, caused by Wuchereria bancrofti, is responsible for the vast majority, or 90% of cases of filariasis. It is found throughout the tropics, while Brugian filariasis, caused by either Brugia malayi or Brugia timori, is limited primarily to rural areas of South and Southeast Asia. This image shows a pair of W. bancrofti nematodes. The adult female worm, shown on the bottom of the image, is significantly larger than her male counterpart shown on top, measuring an average of 10 centimeters in length compared to an average of 4 centimeters in length of the male. Lymphatic filariasis is transmitted by 3 different mosquito vectors: Aedes mosquitoes in urban and semi-urban areas, Anopheles mosquitoes in rural areas, and Culex mosquitoes in the Pacific Islands. The life cycles of Bancroftian and Brugian filariasis are similar and begin with the introduction of nematode larvae to the human host during the blood meal by an infected mosquito vector. The larvae then migrate to the lymphatic system and mature into adult worms over the course of 3 to 6 months. Adult females subsequently release microfilariae, the pre-larval form of the filarial worm, into the lymph and blood vessels. In turn, unaffected mosquitoes become vectors when they ingest these microfilariae during a blood meal of an infected human host. The microfilariae penetrate through the midgut of the mosquito, transform into larvae within the thoracic muscles, and then migrate to the proboscis where it can be introduced into its next host. Most infections with lymphatic filariasis are asymptomatic. However, acute lymphatic filariasis does occur and usually presents itself as acute adenolymphangitis. This state is characterized by sudden onset of painful lymphadenopathy and fever in a single or group of adjacent lymph nodes, generally in the inguinal nodes and lower extremities, and is due to local inflammation in response to dying adult worms. These symptoms tend to remit spontaneously after 3 to 7 days, but can recur at irregular intervals 1 to 4 times a year. The male genitalia are especially vulnerable to W. bancrofti and can develop orchitis and epididymitis. 2 other clinical manifestations of acute lymphatic filariasis are filarial fever and tropical pulmonary eosinophilia. Filarial fever is defined as recurrent, self-limited febrile episodes in the absence of lymphangitis, while tropical pulmonary eosinophilia presents with nocturnal wheezing and bronchospasm due to inflammation triggered by trapped microfilariae in the lungs. This slide shows 2 examples of acute adenolemphangitis demonstrating painful and cord-like lymphatics with associated red streaking and surrounding edema. Chronic lymphatic filariasis develops after years of inflammation, leading to permanent lymphatic damage and obstruction with non-pitting edema, fibrosis, skin hypertrophy, and hyperpigmentation of the limbs, as seen on the left, and/or massive unilateral or bilateral hydrocele, as seen on the right. Secondary bacterial or fungal infections are common and contribute to worsening disfigurement and disability. Peripheral blood smears are the primary diagnostic modality in resource-limited settings and can demonstrate the presence of microfilariae. The sensitivity of blood smears can be improved by performing them on consecutive days and by drawing samples between 10 p.m. and 2 a.m., given that microfilariae have a nocturnal periodicity that corresponds with mosquito feeding habits. Antigen testing for adult worms is available only for W. bancrofti, but has the benefits of higher sensitivity compared to blood smears, stable antigen levels without nocturnal periodicity, and the ability to detect infection even in the absence of microfilariae. For these reasons, antigen testing is a diagnostic test of choice. Serologic testing is also available, but its usefulness is limited to screening for filariasis in travelers who have had no prior exposures, given that the tests are unable to distinguish between prior and active infection. Furthermore, serologic testing has variable specificity due to cross-reactivity to other parasitic infections. On peripheral blood smear, W. bancrofti microfilariae have a characteristic absence of nuclei in their tails. In contrast, B. malai and B. timori microfilariae have two discrete nuclei in their tails. B. malai is distinguished from B. timori by its more kinked body morphology with dense nuclei. This slide shows two examples of peripheral blood smears, with W. bancrofti microfilariae on the left and B. malai microfilariae on the right. The treatment of choice for monoinfected lymphatic filariasis is diethyl carbamazine, or DEC. However, before treatment is initiated, co-infection with other filarial diseases, loiasis and onchocerciasis, must be excluded. DEC is a potent antiparasitic agent, and mass extermination of adult worms and microfilariae can result in severe adverse inflammatory reactions, including fever, anorexia, headache, nausea, and arthralgias. If co-infected with onchocerciasis, a combination of ivermectin and doxycycline should be utilized. In co-infection with loiasis, treatment is determined based on the microfilarial load. If the microfilarial load is less than 25,000 per ml, then DEC can be safely administered. If the microfilarial load is greater than 2,500 per ml, then albendazole should be initiated prior to DEC to lower microfilarial load to a safer level. Unfortunately, the pharmacologic treatment of chronic lymphatic filariasis only diminishes disease progression, but cannot reverse the existing lymphatic damage secondary to inflammation and fibrosis. Supportive care involving washing the skin and nails, limb elevation, and topical application of antibiotics and antifungals are all necessary to alleviate the discomfort and complications associated with chronic lymphedema and elephantiasis. Surgical intervention is reserved for scrotal elephantiasis, where drainage of hydroceles can provide immediate relief and resection may allow for definitive treatment. On the other hand, reconstructive surgery of the damaged lymphatic system have unclear long-term benefits. Mass treatment programs have been utilized in endemic areas in an attempt to decrease the microfilarial levels in human hosts to below the level needed to sustain transmission by mosquito vectors. In fact, the Global Program for the Elimination of Lymphatic Filariasis has organized annual mass treatment programs with the hope of eradicating W. bancrofti, which, unlike B. malai and B. timori, has no animal reservoirs. In certain countries such as China, India, and the Solomon Islands, DEC has actually been added to table salt since it is both tasteless and stable upon cooking, leading to dramatic reductions in transmission. Personal protection against mosquitoes with the use of bed nets and insect repellent also plays an important role in prevention.